Thank you.
Thank you. I'm going to have ask Dr. Berman to take a few minutes of comment, and then I'm going to go back to Dr. Shaw for a conclusion.
Well, thanks for the opportunity to say a few words. It's been a very interesting symposium. I completely endorse the concept of eradicating heart attacks. I think the Association for the Eradication of Heart Attacks is an excellent association for us all to become involved in. Looking at the evening, I agree with most of the speakers. I'm fortunate to be in a position of running a cardiac imaging section where we do EBCT and we do nuclear testing and we do PET and we do CT, angio, and we do MRI. And in looking at that spectrum, my view of the pyramid coincides with much of what was said. I would point out that I think at the present time when we look at costs, that maybe we have to be careful about how far we stretch that lower limit of the intermediate risk group that might need testing. We noticed earlier Dr. Brownwald and Dr. Fuster both used a 0.5% per year limit, which is even lower than the 0.6% that Dr. Taylor's group had came up with, but it was reluctantly they came up with it because a 10 to 20% is something that would be more reasonable when we look at the proportion of the patients who would be tested and the risk of those patients. We're probably going to have to, in view of limited funds, be aware of that kind of limitation. But I think that starting with, in the intermediate risk group, an acceptance of the value of testing is a good starting place that our society hasn't yet reached. If you're in the Army, you might be able to get this test, but if you're not in the Army, you have to have $400 of spare change to be able to purchase the test because our third-party carriers, even in this clearly defined 10 to 20% risk group, won't pay for the test. Then we go on to the need for further testing, and I agree with the earlier comments that MRI has a big future. I think CT angiography has a future. I think nuclear testing has a future. Exactly where they're going to fit in has to be defined. I found the discussions about cost effectiveness very, very interesting, and just to kind of pull it all together, I think we're all in the same team. And Dr. Callister actually should be joining us up here on the panel because he's one of the leaders of this team whose data has shown us how dramatically the knowledge about coronary calcium can predict subsequent outcomes. But in pulling it all together, I do think it does come back to this: what is going to be the effectiveness of finding the early disease? And if this new organization is right, then maybe the assumption that we will be causing a 30% reduction in mortality will actually be wrong. And in the future, perhaps we will be reducing that mortality by not 30, not 35, maybe 40%, maybe 50%, maybe even farther, at which time then we'll have a marked difference in these cost-effective analyses, as was so nicely pointed out by Dr. Taylor.